That's all right. So I first got introduced to the ASC when I volunteered to join Dr. Sengupta and David Adams for the humanitarian screening event in India. Following that, I joined the BSc, the British Society of Echo, where I joined Professor Mark Monahan and his team to scan children from townships in South Africa for rheumatic heart disease. So today it gives me great pleasure to present to you the quantification of mitral stenosis. So I have no conflicts of interest. I work as a specialised echocardiographer who is BSc accredited in transthoracic and transesophageal echo, and I work at Russell Hall Hospital in the UK. So today we'll briefly discuss the features of mitral stenosis, echo evaluation of this condition, and what other valve disease is also present, and is this mitral valve suitable for intervention? So the mechanism of mitral stenosis is, the most common one is rheumatic valve disease, where you get leaflet thickening, commissure effusion, caudal shortening, and doming, or that classic hockey stick appearance of your anterior leaflet. There's also rare conditions such as degenerative mitral stenosis, where you get predominantly annular calcification associated with hypertension and atherosclerosis. And very rare is congenital mitral stenosis, where you get a parachute mitral valve. So these are the images that I've taken from the protocol that we used in Echo in Africa. So this is a normal mitral valve excursion, and you can see the anterior leaflet tip points upwards towards the septum in maximum diastole in your parasternal short axis view. In your short axis view, the two images at the bottom, you can see that you've got nice thin scallops, you've got good excursion of your leaflets, and you can see the anterior leaflet there shows good excursion in diastole. However, in a rheumatic mitral stenosis, you can see maximum diastole, the anterior leaflet tip points downwards towards the posterior wall rather than upwards towards the septum. In your three short axis views, you can see significant commissure effusion with that classic oval shape in the centre. So these are 2D images, both are rheumatic, both are mitral stenosis. The one on the left demonstrates the thickened leaflets, and the one on the right looks at restricted commissures, particularly the anterolateral commissure. So a parasternal long axis view and a parasternal apical four-chamber view, and you can see that classic hockey stick appearance of the anterior leaflet pointing downwards towards the posterior wall, and the restriction of that posterior leaflet as well, and the left atrium also appears dilated on that view as well. So how do we quantify this? Well, I've used these guidelines for the purpose of this presentation. This is a paper from 2009, and it recommends that we use planimetry, which is gold standard, pressure half-time, the mean pressure gradients, left atrial size, is there pulmonary hypertension present, and how do we score this in view to intervention? So let's start off with planimetry. So we trace around the basal short axis view, and you trace the inner edge of your mitral valve orifice in diastole. Scan at the mitral valve tip, so sweep your probe back and forth so you're away from the papillary levels and right at the basal level of your mitral valve. Check your parasternal short axis view AP diameter versus your diameter in your plaques view. So if you have your long axis view, measure with your calipers, measure the anterior posterior excursion. You should be able to get similar readings in your parasternal short axis view. So what are the caveats? Well, if there's excessive gain, this may underestimate your valve area. It's better to zoom in for better delineation. So you can see here, there's an unzoomed image where you get a planimetry of 1.4 centimetres square, and then you get, with a zoomed image, it's 1.3 centimetres square. So this would be the difference between mild to moderate mitral stenosis or moderate to severe mitral stenosis. Also, if the patient's in AF, ensure that you can take multiple measurements and use a high frequency transducer for better resolution. And look at your harmonics, because this may affect your leaflet thickness. In a heavily calcified valve or chest deformation, you may get inaccurate planimetry. And if you have an off-axis parasternal long axis view, then you may overestimate your mitral valve area when you trace around it in your short axis view. There's also pressure half-time, and this reflects the pressure to equalize across an orifice or an obstruction. So these are the measurements that are involved, and your machine should automatically do this for you. So mitral valve area equals 220 divided by your pressure half-time. So the shorter your pressure half time, the pressure equalizes rapidly, suggesting that there's minimal obstruction to that valve, so there's a big orifice. The longer your pressure half time, the pressure equalizes slowly, so it's suggesting that there's a significant obstruction to the flow there. So this is a mild mitral stenosis. This is a moderate mitral stenosis. You can see you've got pressure half times about 146 and 145. And then this is a severe mitral stenosis, and you can see this patient's actually gone into AF there. If you do get a bimodal trace, like the second Doppler profile, you have an early descent of that E wave due to rapid filling. Try and measure mid-diastole for an accurate reading. Patients in AF, try and avoid your short cycles and stick with your longer cycles, which show less RR variation. So what are the confounding factors? Well, if there's aortic regurgitations, if you've got an impaired LV systolic function, if there's LVH or you have a shunt, if there's stiff LA, low LA compliance, this will shorten your pressure half time and underestimate your mitral stenosis. So overall, overestimation of your mitral valve area by pressure half time. Also, if you have mild mitral stenosis, it's unreliable, so it's better to perform telemetry, because that will have less calcification of the valve. There's also your mean gradients where you can assess mitral stenosis. This is where you measure your diastolic pressure gradients, and you can obtain this using your apical 4-chamber view, where you trace around your E to A Doppler profile to get an VTI. So use your simplified Bernoulli equation, which is your 4V square. So mild is less than 5 millimeters of mercury, and severe is greater than 10 millimeters of mercury. So this is a mild mitral stenosis, and you can see a mean gradient of 4.65. And this is a severe mitral stenosis, and you can see a mean gradient of about 16 millimeters of mercury. But what you need to take into consideration here is, if you have high flow, you will get high gradients. If the patient's pregnant or if they have a mitral regurgitation or tachycardia, you will get high gradients through this valve. Additional measurements that can be performed. As sonographers, we don't normally perform these, but there is a continuity equation, which is your conservation of mass. But there is contraindications to this. If the patient is in AF or you have significant mitral regurgitation or aortic regurgitation, then it's inaccurate. There's also the PISA method, which assesses the mitral valve flow volume, and so you get that classic candle flame appearance on the LA side, and this can be used if the patient does have MR. And more importantly, exercise echo. So you assess symptoms and gradients. So if you exercise the patient and their mean gradient is greater than 15 millimeters of mercury, and their pulmonary systolic pressures are greater than 60 millimeters of mercury, then this suggests significant mitral valve disease. So these are the severity classifications taken from those guidelines, and the ones that we need to look closely at are the severe categories, because at this point this patient would probably need intervention. Other factors that you need to take into consideration is the LA dilated. If it is, ensure that you can measure LA volumes using your body surface area. Is a patient in AF? Is there spontaneous contrast? Is there stasis in the heart? Because we need to ensure that this patient has a TOE to look at left atrial appendage clot or thrombus. Mitral regurgitation, we need to quantify this, because anything greater than mild mitral regurgitation is a contraindication to percutaneous balloon commissurotomy. And also right heart disease. What are the pulmonary systolic pressures? Because if you have a tricuspid annulus greater than 40 millimeters, this is a reliable predictor of severe TR developing late after surgery. And finally, aortic stenosis or mixed disease. So mitral stenosis may underestimate UAS due to reduced stroke volume not generating a sufficient gradient. So this is the Wilkins score, and this assesses predominantly your anterior mitral leaflet tip. You look at the mobility of the leaflet, you look at the thickening, the calcification, and the subvalvular thickening. And each area is scored out of 4, so a total of 16 marks. If you have a total score of less than 8, then this is likely to be a successful percutaneous commissurotomy. So this is an example. So you can see an apical 4-chamber and a long axis view, and you can see there's diffuse disease of the anterior leaflet with heavy calcification at the tip. There's also subvalvular involvement. So if we go back to the Wilkins score, we can see that we're grading this mainly 3s and 4s. So this patient would probably be unlikely having a percutaneous balloon commissurotomy. Coming on to 3D, well, this can be performed using transesophageal echo and transthoracic echo, and it gives us higher accuracy than 2D, gives us detailed information on commissure involvements and valvular involvement that we may not be able to see on 2D. And it's superior mitral valve area measurements by planimetry in a calcified valve. So this is a paper, this is a study that was performed by the King's College Group in London, and it looked at two-dimensional planimetry versus 3D transesophageal planimetry in patients with mitral stenosis. And you can see that there's good correlation between the two. However, it did show that 2D planimetry does overestimate mitral stenosis by 0.2 centimeters square. So this is an example of a 3D data set, and it looks at multiplane reconstruction, and it's an off-axis transthoracic view. And as I mentioned earlier, if you perform an off-axis view in a 2D, this may overestimate the valve area. So with 3D, if we can use multiplane reconstruction, we can align all these scan lines right at the tip of that mitral valve, so we can accurately assess the mitral valve area by planimetry. So we're just moving these scan lines, so we're not at the body or the base of the valve, so we're right at the leaflet tips. So this will play just for a few seconds. So you can see we're just aligning it just at the tips of the mitral valve in all these cross sections, and then hopefully we should be able to crop this and perform a mitral valve area. So this is your cropped view, so if we can trace this using so this is one of the benefits of using 3D transthoracic echo. So in summary, quantitative assessment of mitral stenosis is better than qualitative. Echo is key in determining patient management, and always remember your associated lesions like your right heart. Is there spontaneous contrast? Because as sonographers, we need to report a descriptive report, because this team here, or the team in your department or your hospitals, would like to know whether the symptoms correlate with your echo findings, because then they can decide whether this patient requires a percutaneous balloon commissurotomy or a valve replacement. Thank you.
Thank you, G. That was great. Next, we have Rick Reese from St. Thomas Health Services from the Greater Nashville area.
Thank you very much, and again, thank you,